There is something happening in medicine right now that is robbing millions of seniors of their memories, and most doctors aren't telling their patients about it. Not a virus, not a new disease. It's the medications sitting in your medicine cabinet right now. Some of the most commonly prescribed and over-the-counter drugs in America have been scientifically linked to accelerated memory loss, rapid cognitive decline, and dementia. We're talking about pills for sleep, allergies, heartburn, anxiety, bladder control, medications that millions of people over 60 take every single day, thinking they're helping themselves. Today I'm going to walk you through 9 of the most dangerous offenders, and I'm going to tell you exactly what to ask your doctor, because this is a conversation that should be happening in every clinic, and it isn't. If someone you love is a senior, please watch this all the way through. This information can protect their brain. I've been practicing medicine for over X years, and one of the most heartbreaking things I see is families watching a loved one's mind slowly fade and believing it's just normal aging. Sometimes it is. But sometimes, more often than medicine admits, it's the medications. Here's what most people don't know. The aging body processes drugs completely differently than a younger body. The liver slows down, the kidneys filter less efficiently. Body fat increases, which traps certain drugs. And critically, the blood-brain barrier becomes more permeable with age, meaning more drugs can reach the brain than ever before. This is why a drug that's perfectly safe for a 40-year-old can be quietly catastrophic for a 75-year-old. And it's why medical organizations like the American Geriatric Society publish what's called the Beers Criteria, a list of medications that are potentially inappropriate for older adults. Many of today's 9 drugs are on that list. Before we go through the list, you need to understand one key mechanism, because it explains most of today's drugs. Many of these medications are what we call anticholinergic. They work by blocking a neurotransmitter called acetylcholine. Acetylcholine is critical for memory, learning, attention, and muscle control. It's so central to cognitive function that the main drugs we use to treat Alzheimer's disease work by boosting acetylcholine. So when you take a drug that blocks acetylcholine, especially long-term, you are essentially doing the opposite of an Alzheimer's treatment. You are reducing the very chemical your brain needs to form and retrieve memories. Research published in JAMA Internal Medicine found that people taking anticholinergic drugs were up to 47% more likely to develop mild cognitive impairment. And a systematic review found that anticholinergic use for 3 or more months increased dementia risk by an average of 46%. These aren't small numbers. Now let's go through the 9 medications. Number 1, and this one is in almost every home in America, Diphenhydramine. You know this drug. It's the active ingredient in Benadryl, Zaquil, Unisom, Tylenol PM, Advil PM, and dozens of other over-the-counter sleep aids and allergy medications. Diphenhydramine is one of the most potent anticholinergic drugs available without a prescription, and it is absolutely everywhere. The American Geriatric Society has listed it as potentially inappropriate for older adults for years. Why? Because in seniors, it doesn't just cause drowsiness, it penetrates the brain easily and blocks acetylcholine aggressively. Short-term effects include confusion, delirium, and memory fog. Long-term regular use has been linked to lasting cognitive damage. And yet, because it's sold at every pharmacy and gas station, most people assume it's completely safe. If you or a loved one is regularly taking Benadryl to sleep or for allergies, please stop and read the label. Then call your doctor. There are far safer alternatives: loratadine or cetirizine for allergies, melatonin or CBTI techniques for sleep, that do not carry this brain risk. Number 2, overactive bladder medications, particularly oxybutynin and tolterodine. Overactive bladder is extremely common in older adults, and these medications genuinely help with urinary urgency and incontinence, but they are strongly anticholinergic, and the research on cognitive risk is serious. Studies have specifically flagged oxybutynin as having some of the highest anticholinergic burden of any prescribed medication. Even researchers studying bladder drugs note that two of the most common oxybutynin and tolterodine may carry higher risks of cognitive decline compared to other options in the same class. The good news, there are newer bladder medications, like mirabegron, that work through a completely different mechanism and do not have anticholinergic effects. If you or a loved one is on bladder control medication, ask your doctor specifically about mirabegron as an alternative. It's a conversation worth having. Number 3, and this one is one of the most widely prescribed drug classes in the world for seniors: benzodiazepines. Alprazolam, that's Xanax. Lorazepam, that's Ativan. Diazepam, that's Valium. Clonazepam, Klonopin. These are prescribed primarily for anxiety and sleep disorders, and they are extremely effective in the short term. But long-term use in older adults is a different story entirely. Benzodiazepines enhance the action of GABA, a brain chemical that slows everything down. In seniors, this suppression doesn't bounce back the way it does in younger people. Long-term benzodiazepine use has been directly associated with higher rates of Alzheimer's disease and overall dementia. Among the specific drugs most frequently linked to Alzheimer's are alprazolam, lorazepam, and diazepam. The American Geriatric Society recommends avoiding benzodiazepines in adults 65 and older for anxiety and sleep, specifically because of fall risk and cognitive effects. Beat, empathetic tone. I want to be clear, stopping benzodiazepines abruptly can be dangerous and requires medical supervision. If you've been on these long-term, do not stop suddenly. Talk to your doctor about a slow, supervised taper and about alternatives like cognitive behavioral therapy for anxiety, which evidence shows works as well or better long-term without the brain risks. Number 4. Tricyclic antidepressants, particularly amitriptyline and nortriptyline. These older antidepressants are still commonly prescribed, often not for depression, but for nerve pain, migraines, and sleep, and they carry significant anticholinergic burden. Amitriptyline in particular is on the Beers criteria and has been flagged by multiple geriatric medicine organizations as inappropriate for older adults. The combination of sedation, anticholinergic effects, and the risk of orthostatic hypotension, dizziness when standing up, makes this drug particularly problematic for seniors. Newer antidepressants, SSRIs and SNRIs, treat depression with far less anticholinergic burden, and for nerve pain, there are alternatives like gabapentin or topical lidocaine that your doctor can discuss. Ask, is there a reason I'm still on this older medication rather than a newer option? Number 5. Proton pump inhibitors, PPIs. These are among the most prescribed medications in the world. Omeprazole, esomeprazole, lansoprazole, sold as Prilosec, Nexium, Prevacid. Millions of seniors take these daily for heartburn, acid reflux, and stomach protection. And here's where I have to be nuanced with you, because the science on PPIs and dementia is genuinely mixed. Some studies show increased risk, others show no link. But here's what we do know. A large study found that prescribed PPI use for more than 4.4 years was associated with a higher incidence of newly diagnosed dementia. And observational data has shown associations, particularly with long-term use in older patients over 65. The proposed mechanism involves B12 deficiency. PP is reduce absorption of B12, which is critical for brain health, and changes to the gut microbiome, which increasingly we understand has direct effects on brain function. Important nuance. Many seniors who need PP genuinely need them, for ulcer protection, for Barrett's esophagus, for serious reflux disease. I am not saying stop your PPI, I am saying ask your doctor if you still need it at the current dose and duration. Many people are on PPIs indefinitely when they were originally prescribed for 8 weeks. That conversation is worth having. Number 6. Antipsychotics in seniors without psychosis. This one concerns me deeply as a physician. Antipsychotics like quetiapine, risperidone, and haloperidol are sometimes prescribed to older adults for sleep, agitation, or behavioral issues, especially in dementia care, despite FDA black box warnings about increased mortality in elderly dementia patients. These drugs heavily sedate, increase fall risk, worsen cognitive function, and, critically, have been linked in research to accelerated cognitive decline. Using them in seniors with existing dementia can make the dementia progress faster. The Beers criteria explicitly flags antipsychotics as inappropriate for behavioral symptoms of dementia unless non-drug interventions have failed. Non-drug approaches, structured routines, sensory therapies, caregiver training have significant evidence for managing agitation in dementia without the cognitive cost of antipsychotics. Number 7. Opioid pain medications, particularly long-term use. Opioids suppress the central nervous system. In acute pain management, they're sometimes unavoidable. But long-term opioid use in seniors contributes to sedation, confusion, delirium, and over time has been linked to measurable cognitive decline. Prescription opioids have been associated with increased risk of dementia in observational studies, and the cognitive effects compound with other sedating medications, creating a dangerous synergy that's often underappreciated. Pain in older adults is real and deserves treatment. But opioids should be the last resort, not the default, and the cognitive cost should be part of the pain management conversation. Number 8. Muscle relaxants like cyclobenzaprine and methocarbamol. These are commonly prescribed for back pain and muscle spasms, and in seniors, they are disproportionately risky. Cyclobenzaprine in particular has significant anticholinergic activity and heavy sedating effects. In older adults, muscle relaxants increase fall risk, cause confusion and disorientation, sometimes described as brain fog, and in the context of already reduced brain reserve, regular use can meaningfully worsen cognition. Physical therapy, gentle stretching, topical anti-inflammatory creams, and warm/cold therapy are often just as effective for muscle pain without any cognitive risk. Ask your doctor whether a muscle relaxant is truly necessary or whether there are safer options. And number 9, older antihistamines like chlorpheniramine and hydroxyzine. These are found in many combination cold and allergy products, and hydroxyzine is also prescribed for anxiety and itching. Both are strongly anticholinergic, and both regularly appear on the Beers criteria as inappropriate for seniors. The problem is that they're often invisible, embedded in multi-symptom cold products where the label doesn't make the anticholinergic risk obvious. A senior taking a nighttime cold medicine and a sleep aid might unknowingly be doubling their anticholinergic burden. Newer second-generation antihistamines, loratadine, Claritin, fexofenadine, Allegra, cetirizine, Zyrtec, are far less likely to cross the blood-brain barrier and are much safer choices for older adults. Before I tell you what to do, I need to talk about something called polypharmacy, because it might be the most dangerous issue of all. The average senior takes multiple prescription medications daily. Studies show that 1 in 3 seniors taking anticholinergic drugs takes an average of nearly 5 of them simultaneously. Each drug on today's list has cognitive risks individually, but combined, the effect is compounded. We call this anticholinergic burden, the total load of brain-blocking activity across all your medications at once. A senior taking a bladder medication, a sleep aid, an antihistamine, and an older antidepressant simultaneously can have a catastrophic combined anticholinergic burden, producing symptoms that look exactly like early dementia. And here's the cruel irony. Sometimes, when a senior shows signs of confusion and memory loss, the response is to prescribe more medications for the symptoms, worsening the underlying drug-induced cognitive problem. A careful medication review, ideally with a geriatrician or clinical pharmacist, can sometimes reverse what appears to be dementia in a matter of weeks. I've seen it happen. It is one of the most rewarding things in medicine. So here's what I want you to do. right now. First, make a complete list of every medication you or your loved one takes, prescription, over-the-counter, supplements, everything. Include doses and how long each one has been taken. Second, bring that list to your doctor and ask these exact questions. Are any of these medications on the Beers criteria for older adults? Do I still need each of these, or were some started for short-term problems I no longer have? Are there any on this list with significant anticholinergic effects? Is there a safer alternative for any of these? Third, ask for a medication review with a clinical pharmacist. In many health systems, this is a free service, and pharmacists are specifically trained to spot dangerous drug combinations that doctors sometimes miss. Fourth, never stop any medication abruptly without medical guidance. Some of these, especially benzodiazepines, can cause serious withdrawal. The goal is a supervised, thoughtful review, not a panic. Memory loss is terrifying. Watching someone you love drift away is one of the most painful things a family can experience. But if that decline is being driven, even partly, by medications that can be changed, that is a problem worth solving. And it starts with a conversation. If this video helped you, or if it made you worried about someone you love, please share it right now. Send it to a parent, a sibling, a friend who's on multiple medications. This information belongs to everyone. Drop a comment below telling me which medication on this list surprised you the most. I read every single comment, and I respond as often as I can. If you haven't subscribed yet, do it now. We talk about evidence-based senior health every week. No supplements to sell. No sponsors telling me what to say. Just honest medicine. Take care of the brains of the people you love. They're counting on you.